momentarily. Just a couple of kickoff comments. We are very excited for this evening. I know when we are talking about a change in compensation, it creates some anxiousness with people, and we totally understand this, but we couldn't be more excited about this journey that we're embarking upon. We have had a revenue minus expense primary care comp model. I've been in this role for 13 years, and it way predates me. I mean, Dr. Castillo could tell us how long it is, and it's been going back to the St. Luke's days in terms of that compensation model. And quite honestly, as a quasi-private practice model, for those years, it really worked well for us. In large part, was propped up by some pretty robust managed care distributions that we received at year's end for years and years and years through Blue Care Network and Health Plus. And it was kind of a running joke for years that, okay, these are going to go away at some point in time. These are going to go away at some point in time, and they just didn't. They've hung on for years. And quite honestly, we still have a situation through both pay for performance and quality initiatives through the PHO, as well as managed care incentives, that there's still a remnant of those. And quite honestly, a little bit more, and Lynn can speak to this, a little bit more than what we had anticipated on a go forward. But in large part, the model just wasn't working for us. And again, Kevin will speak to kind of some industry standards with respect to that. So Kevin is with CBiz, and again, I think he can give a little bit more background about himself individually. But we've had a relationship between CBiz and Covenant for probably about 12 years. Primarily, a bulk of their work has been practice evaluations. When we acquire an independent practice, they help us value it. We have to have an arm's length valuation in order to stay legal with those arrangements. Also, if somebody triggers the soft cap, if a physician gets above 130% of the 90th percentile, we have to have a fairness opinion done on that work, and CBiz has done that historically for us. They do a lot of compensation work, but quite honestly, our models have been not that robust historically, both on the specialty side and the primary care side. Most of our specialists are in a work RVU model, but it's not a robust model like what you'll see this evening. So again, very excited about this. Again, know that there's some anxiousness to this. We want to introduce the concept this evening, talk about it, and then spend some time in the days and months ahead, just really talking both collectively and individually in terms of how this is going to affect you. One final comment, I'll turn it over to Kevin. When we first started on this journey, we thought, okay, we're going to have a revenue minus expense or a work RVU incentive compensation system. And there was some discussion of, are we going to have to carry two models on a go forward and have folks make a decision about whether they want to stay in a revenue minus expense or jump over to work RVU. The ingenuity of what you're going to see tonight is that the work RVU compensation model that you're going to see this evening still has a revenue minus expense component to it. So rather than revenue minus expense or work RVU, we actually have a revenue minus expense and a work RVU model. So again, I'll leave the details to Kevin, but that was a huge light bulb moment, and a very nice feature of what CBiz helped us come up with. So with those introductory comments, Kevin, take us away.
All right.
So I'm Kevin Walker, and I work for accounting and consulting company called CBiz. I'm a CPA. CBiz is a large national accounting and consulting firm across the country, 35 major markets. I'm out of our Kansas City office. So Kansas City is home to me. And as Dave mentioned, I've been coming to Saginaw and or doing projects remotely for them for about 12 years now. Me specifically, I started in public accounting over 30 years ago, almost started immediately in the healthcare industry. Back in '87, spent 6 years in public accounting, and then I left public accounting and went to work for a couple of hospitals and a national physician practice management company. The practice management company, National Practice Management, was in the oncology space. I worked for two different hospital systems in Kansas City in both operation roles and finance roles. The compensation plan we're going to talk about tonight is something that I actually worked to develop with the administrative team I was part of and the physicians that we employed. Ultimately, we had, between primary care and specialists, we had about 250 employed doctors. The primary care docs were on a compensation plan similar to this. And then about 15 years ago, I left that hospital environment and I went and joined, and so I've been doing consulting for the last 15 years. Between compensation structure, strategic acquisitions, and valuation type work. So that's my background that I bring to this. Just a couple of slides about background. Dave mentioned this a little bit, but I come in, I've done a lot of work. I've done work on some of your practice acquisitions, but I haven't done too much as it relates to the primary care compensation plan, because you guys have had a revenue minus expense compensation model. As I stand there at 30,000 feet and I look at it and I say, well, you're similar to other markets in that the base amount of your reimbursement is fee-for-service reimbursement. The strategic advantage, or the advantage that you had, was your PHO and the insurance companies and managed care companies behind it had some very material, significant PHO incentives. And so with those incentives and the revenue that was generated from those, and the market where you could control cost, you had an ability to have a profit margin and a compensation plan that shared in that. It served everybody well for a lot of years. The current consideration, as I came in and I worked with Dave and the team and I looked at it, only a minority of the docs are in a position where they can take advantage of that. Combination of reimbursement, fee-for-service reimbursements have come down, managed care bonuses have come down, costs have increased. You take away that ability to make a profit within your practice, and that incentive isn't there the same as it was. And so that's led us to, is there a better model, and what does it look like? From a national perspective, both on consulting projects I do, market surveys that I read and have access to, the national market has almost exclusive fee-for-service reimbursement. The reason I keep mentioning the revenue side, the fee-for-service reimbursement, is because we're going to talk about a compensation plan that aligns the incentives of what's important to you and what's important to Covenant. And if your incentives are aligned, then you're not diametrically opposed to each other. You're rowing in the same direction. And the hospital reimbursement is a fee-for-service. The more volume you have, the more revenue you have. The professional side, on the actual payments for your services, is almost all fee-for-service reimbursement. So with the primarily a fee-for-service reimbursement world, over the last 20 years, the most common compensation plan is something that has a fair base salary. We'll talk about what a fair base salary means. But really, almost all the opportunity falls in the line of a productivity bonus opportunity. And within that productivity bonus opportunity, the work RVU compensation plan is by far the most prevalent. I looked up some of the current market data. We'll talk about some of the three major producers of compensation market data are MGMA, Medical Group Management Association, American Medical Group Association, and the Sullivan Cotter Consulting Firm. And they publish pretty extensive compensation studies, and within that they show the demographics. And out of the first two, MGMA and AMGA, they report that 80% of the docs in their survey are on an RVU-based compensation opportunity. And Sullivan Cotter reports that 72% of theirs. So my guess is if you talk to some of your colleagues in other cities or folks who went to medical school or otherwise, there's a better than average chance that if you ask them, are you familiar with an RVU-based compensation plan, you're usually going to get a yes. So it's very prevalent. The other thing is the fee-for-service reimbursement market and the RVU productivity compensation piece just go hand in hand. But as what we have seen is that the hospital health system employers have said there are other things the reasons that you're important to us besides just generating as many RVUs as you can. And right now in the national market data, about 8% of the physicians who are on a productivity-based compensation plan, 8% of the money comes from non-productive measures, quality measures. So it's 92% fee-for-service, 92% productivity off of your RVUs, and 8% for some other quality measures, and we'll talk about what some of those are. The rest of the country is a little bit the opposite of what you are. They're all sitting there on the cusp of hoping that the managed care companies and Medicare are going to start paying them huge bonuses in primary care. CMS has published that they're moving toward a risk model. Right now it's voluntary. Every market is different. Even when you talk about Blue Cross Blue Shield, it's not really one company all across the country. They're little regional, almost like little franchises, and they make decisions completely independent of each other. But there's been talk for years about we're going to start finding ways to bonus primary care doctors and the management of it. So far, I'd say it's largely talk. They're just not putting the money behind it. Most of the hospitals that I go into, the money that they receive on the revenue side that comes from something besides fee-for-service is usually less than 3% of what they receive. So the rest of the country is saying, well, this RVU-based productivity comp plan is working well for us, but we want to get prepared for being able to tap into these value-based or non-productivity-based bonuses that the managed care companies are, and how do we align with it? And it's a little bit of wait and see. Until we see what kind of money they're putting behind it, we don't know what to build. You're one step ahead of that in that we know what kind of history the PHO has, and we got to capture that and make sure we reward for it. So we're going to walk through the new compensation plan, and some things I want to say about it is it has several components and they're additive to each other. So it's not just one number. There are multiple rewards that all add up, and when you look at it and you say, okay, does this feel fair? How does this add up for how hard I'm working and what I want to make? You have to consider all of the parts. The other thing that I want to talk about is we're going to go through the compensation plan, the RVU piece, the quality piece, the managed care bonus piece, and all of that. But recognize sitting over all of that is the revenue minus expense model is there. It's unchanged. If your department, if the way they calculate your revenue minus expense continues to show a profit, that profit is shared with you exactly the way it is now. The only thing that might be different is one of the things that's charged to your department is your salary, your compensation. And so there may be more compensation with the different bonuses, with the productivity bonus and the quality bonus. It might have a different charge to it. But when you look at ultimately the revenues, including the managed care bonuses, minus the direct expenses and the overhead allocated, when it shows a profit, the sharing of that profit is unchanged. The opportunity is still there. So we're going to walk through the components of it first and explain the decisions we made, and then we'll move in and we'll put numbers on those and show you how the plan works from a numbers standpoint. Let me turn the page here. So as I mentioned, there is a guaranteed base salary. That's there for several reasons. One, you need some security on what you're going to make. There are things that are taken out of your salaries like health insurance or retirement contributions. There's got to be some base there for that. When we look at that, we have a consideration. If we set that base salary too high, then being able to earn above that base salary from a productivity standpoint is a bridge too far. It's like, wow, that's a lot. It's twice as many patients as I'm seeing now or something like that. If you set it too low, you certainly have the feeling of, well, that's not fair. You're just holding on to my money and I have to wait for my productivity bonus to get that. So there's a balance as to what is fair. And we'll talk about what balance we got to on that. The second grouping down is not that important to you guys because it's a new hire opportunity. I guess the reason it is important to you is as we need to continue to grow, we're going to have to compete for new hires. And one of the tools we have to use are signing bonuses. So new physicians may be offered signing bonuses. The part that I want you guys to know about it is if they have a signing bonus, when they get to their productivity bonus, they have to recover both their base salary and their signing bonus, and then they would get a productivity bonus after that. So the real core of the control of a compensation plan like this for you guys is the bottom section on here, the production incentive. So it's got to be fair market value and commercially reasonable, but we can look at it and say, well, we're looking to design a conversion factor that pays you for each RVU you see over that threshold that covers your base salary. We've developed a tiered compensation plan, and when we get to the page with the numbers, you'll see what I mean by that. It means there's a lower tier at a production below about the 35th percentile. Then as you produce a little higher, there's a tier that goes up to the 60th percentile, and then there's a highest conversion for the third tier up above the 60th percentile. It's a very rewarding program in that when you get to that next tier, it gives you that conversion factor back to the very first RVU. And we'll talk about how the reward part of that works by reaching that next tier level. So this is the core of the part you can control with production. As I mentioned, across the country, there's about 8% on non-productivity measures. And that's what falls into our category here. That's the quality incentives. So we have a plan that's additive to the production that goes toward the quality elements. We'll introduce in concept what they are, but we don't have the exact thresholds, and I'll explain that as well. But it's going to give you about a 10%, a little less than 10% more than your productivity comp as an incentive on those quality elements that we've built into it. The next item down is the managed care bonus. And this is where I was talking previously saying the rest of the country is hoping for bonuses for value-based stuff. You've already got them in place. So there are, you see your PHO checks, or you're aware that the PHO checks come each year. Right now, you have an opportunity to share in those PHO checks if it throws your department into a positive, into a profit, and then you share in how that results in a profit in your department. This is a little different from that without taking that away, in that we're going to give you a percentage of that PHO bonus regardless of whether your division's in a profit or not, or whether your department is in a profit or not. So 100% of you will be rewarded in some fashion for those PHO bonuses at a minimum level. But then if your department's in a profit, you'll share in it exactly the way you share in it right now. Student loans are again only specific to new hires. Student loan bonuses and payouts are part of recruiting as well. It's not going to be in the modeling we're going to look at tonight. The next line down is the advanced practice provider supervision. Again, I would characterize your current situation is that if you have an APP and they contribute to the revenues in your department, and those revenues they contribute are in excess of their comp and benefits, they'll contribute to the bottom line. And if your department is in a profit situation, then that goes into the bonus you receive on the revenue minus expense model. Again, that won't change if that's what the result is, but we're putting in an APP supervision that just acknowledges throughout the year, again, whether your department's in a profit or loss position at all, there's a burden on your time and talents to supervise that APP. So there'll be a payment through the year that's additive to your compensation plan if you're supervising an APP. The amount is one flat rate per APP. So if you're in a practice where two of you are supervising one, or you're sharing the supervision, we can split that amount between two providers. If we have two APPs shared by three, we can do the math and share the fee across everybody who has a role in supervising the APP. One more slide, then we're going to move to actual numbers, and that's where I really like to start talking, is with numbers. I've mentioned already the shared profit or the revenue minus expense model is not going away. The compensation that's charged against your department is going to be driven by the elements up to this point. But if your department is in a profit, then it's the same as it has historically been. And hopefully we can do things to enhance the revenue and put more of you into a profit position, but certainly it's nothing that's taken away from you. The last thing I want to mention that's a part of the compensation plan, and this goes to compliance reasons, is there is a soft cap that's always been there. And that soft cap just says if a physician gets to a certain amount, we've got to have some certain review to make sure that we know the risk that we're taking. It's nobody necessarily in this room's decision that we need to do that. It's the compliance environment nationally. The other thing is if anybody earns at that higher level of comp, above that soft cap, above the 90th percentile, it's got to be because the profit in your department is there to support it. So that's a compliance thing. We just would run into a really tough situation if we were losing a material amount of money on employing a doctor and they were earning up in the top decile or higher of compensation. So once you get above that cap, currently you'll see in the modeling that's $370,000 a year. Once you get above that 370, we just can't be in a situation where the health system is losing money and or supporting you financially. So you'll see that modeled as well. So we're going to walk through the numbers, how they apply to you. I guess one thing that I'll point out is Lynn handed out to everybody your current RVUs. I will tell you that, based on this, my experience with physicians on this model, if you casually or generally know how many RVUs you do right now, you get the report, but you don't look at it for a few days. In the future, you'll look at this report, and if Lynn doesn't send it out on time, you'll be calling and saying, why didn't the reports come out? Because it has such a direct, and right now, any bonus you get, you're sitting around and waiting till the end of the year. It's largely dependent on the PHO bonus, which you feel out of control on. Your productivity bonus is going to be much more connected to the work you feel like you're doing.
Just to orient folks to that report, the numbers that we're going to be seeing up there are annualized numbers. So I think is there a rolling 12?
The very far right column is annualized.
Thank you, Lynn. I'm sorry. Thank you.
This is a very common compensation model format that I go over. I've got some pages next that are a little bigger and more readable. So we're going to go through the top box first, and that's all of the elements we just talked about and putting the actual monetary parts on them. And then down below shows how it would play out at each of those compensation levels. So the box across the top has all of the same compensation elements, and it now says, okay, here are the values assigned to that. So the first one that we talked about back on there was the base salary. So it would be set at $390,000. Or, what did I say? Oh, 390. Don't record that part. I just did that, see if you're paying attention. Mostly Dave.
Can I just ask one question just on this, just because I see the bases are across the board here? What's the RVU for the base? Is it 60th percentile national average of the MGMA, or what is it national percentile rank, and what does that national percentile rank RVU for that compensation?
Let me see. I'll answer the question the way I think it was asked, but if I don't answer your question, let me know. We set the base in concert with all of the pieces, and is what we really care about is when we get to the whole compensation piece, which is this column over here, is that fair relative to each level that you're working? And the productivity piece is one part of it. The base matters from this line up because there is no productivity piece. But even at those levels of production, we want to make sure that this compensation that doesn't have a productivity piece is still a fair compensation. So the 190 is not in any book anywhere specifically, it's not at any percentage, but it's the number that goes with the rest of the pieces to make it so the total compensation package is fair.
All right, I'll let you do your part and then I'll kind of, I'll hit it at the end.
Try and understand it.
Okay.
So Kevin, maybe just to expand upon this question, at 5,200 work RVUs, is that the point where the 60th percentile comes into play?
Yeah.
On that last graph?
Yeah. So it's not necessarily the 190 that's a part of it, but so the base salary is the first component of the compensation plan. The next is the productivity. And so the comp per work RVU then becomes critical. And what is that productivity comp? That's over here in this box to the right. And I mentioned we have 3 tiers. The lowest tier is generally below 35th percentile of RVU production. So for everything from 0 to 4,400 RVUs, the conversion factor would be $41. On the second tier, which is about 35th percentile RVUs up to the 60th percentile RVUs. So 60th percentiles are right around 5,200 RVUs. That's in the second tier, and the conversion factor goes up to $44. And again, that's on every RVU. We'll talk about how that works when we go back to the bottom half of this page. And then on the third tier is those getting at 60th percentile RVU production or higher, gets to the highest conversion factor of $46. So that's the base salary and the productivity salary. Anybody above 4,400, so it's really math going backwards saying, well, what's 190 divided by the conversion factor to say at what point do I start earning a productivity bonus? And with those conversion factors, it's when you get out of the first tier into the second tier. So really anybody above 4,400 RVUs really cares on an annual basis more about this number than the base salary. And we'll come back, the base salary is actually going to be the greater of 190 or 85% of your production, but that's on a page to come. The second part of the compensation is your quality component. And we have it pegged at $4 per work RVU. And so I want to explain how you would earn that quality bonus. We've put it into 3 categories of opportunity to earn toward that. Those categories are these first 3 columns with the quality box right here. There's a little bit more narrative on page 11 about those, but it's not legalese yet. It's not down to the very minute detail, and it doesn't have the exact thresholds. It's in there as the concepts that you'll learn more about. But essentially, there will be patient experience, your patient satisfaction scores. You know, it's beyond how busy are you, do patients like you? And that's important to us. It's an important thing for the organization. So that's why there's an amount attached to that. So there will be scores or thresholds assigned to that, and if you reach that highest threshold, it'll be a bonus of $2 per work RVU. There will be thresholds below that where you'll earn a portion of it if you don't. The second category are what I call the more clinical things, the screening type categories. There again will be the ability to capture, those are largely out of the HEDIS measures, and I went the wrong way. Currently the ones that we're discussing, it's in this screenings category on page 11, is breast cancer screening, colorectal cancer screening, and hemoglobin A1C, diabetes control. So it's your performance on your patient population relative to the HEDIS measures. And if you score above that each benchmark, you'll earn that amount. If you score below it, you'll have something to work on. And then the third category is citizenship. So we ask you guys to come to meetings, to participate in community activities. So there will be a series of community events, social events, staff meetings, things that are important. They're outside of, there's no RVU assigned to them, so instead there's points assigned to them. If you participate and make Covenant Health System a better place because of it, we're willing to put money behind it. And so that would be the third category. The intention would be that we want, out of the $4 available, everybody needs to score better than half. And so that $2 out of the $4 on those scores is your entrance to then get the PHO bonus opportunity. So those things will be measured for you, and you'll understand how you can do them. Those also will be communicated, right? Not just on a high level of saying, we're going to be looking at this, this, and this, and later in the year we'll tell you what the benchmark is. You'll know the benchmark before the year starts. You'll know where the benchmark came from. So that takes care of the $4 per RVU that's additive to the tiers that are over here. The managed care bonus, right now I've populated it with the average of you guys collectively. So the average PHO bonus in fiscal year 2018 was $47,000. You guys, again, before the income minus expense application of it, guaranteed payment out of what is earned as a PHO annual bonus will have 10% of it added to your salary. So many of you, or some of you that have been in a revenue minus expense situation in the past, you've seen the benefit of those payments. But others, where you haven't, even that PHO bonus hasn't taken and gotten you to a profit position in your department, you see that the check came, but none of it benefited you. Right now, everybody will get some benefit from it. And so you'll see a column for that as well. And then the profit percentage is the same. Oh, I'm sorry. One more piece back here, hiding over here in the lower right-hand corner. And that's the APP supervision that I talked about, and that would be $10,000 per FTE of the APP. That could be shared by everybody or anybody who's supervising it. It could be $20,000 if you're supervising 2 APPs. So that would be applied on a specific doc basis as well. So now we have a couple of different pages that walk through and get you an idea together with the RVU pages that you have, and also some of the patient access initiatives on what your RVU goals are. What does that mean? Where would I likely fall? What are my opportunities? So I want to talk about two things. I'm going to go through some of these lines and show you how it adds up and benefits you. And then I'm also, don't let me forget to talk about jumping, or the part of getting between each of the tiers. So I'm going to go through the 3,500 RVU line, the 4,500 RVU line, and the 5,500 RVU line. So the physician that would generate 3,500 RVUs would earn the base salary, but because it's not over 4,401, you would see that they're not in a position where they're earning that productivity incentive. We've populated with the quality bonus opportunity and the average managed care incentive. So for really everybody below the really 4,400 RVUs, but on that 3,400 line, the opportunity for compensation is almost $209,000. If I take out outliers out of your current group, folks on signing bonus or otherwise, if I take them out and I look at what you guys are making historically, the average historical comp is about $205,000. So without getting into working a significantly busier life, this replaces that and doesn't really represent a pay cut. I forgot to mention at the very beginning, when I was hired by Covenant to come in, look at the current situation, make recommendations, there was no part of what Dave and Dr. Martea said that was, hey, we're struggling financially, can you come and find us a way to save 25% or save any money? It was really just, can you find us a way that better aligns what's happening in our payer market, what's happening with our incentives, and how to set up a comp plan for our primary care docs. So there's no intention behind this to look for a way to save a few dollars off the backs of the primary care docs. And that's, I suppose, evidenced by, even before APPs, the average would be above what you guys are earning as an average now. And if you have an APP in your practice, it's even $10,000 higher than that. So on the 4,500 RVU line, the base salary is 190, but because the RVUs are above that threshold, there would be an $8,000 bonus at 4,500 RVUs. That's with the conversion factor. Sorry, my eyes are terrible. With the conversion factor of $44, which is the tier 2 conversion factor. So you essentially take the 4,500 RVUs times the $44 conversion factor, and that equals 196, and you say, well, how much was paid as a base salary, and the remainder is the incentive, the productivity incentive, and that is pretty much consistent down the page. On top of that, you got the quality bonus and the same average managed care bonus, and the compensation opportunity at below median RVUs. Their median RVUs for, depends whether you're in family practice or internal medicine, they're all right around 4,900, 4,950 at median nationally. So 4,500 is slightly below median, but you'd have an opportunity to earn $221,000, and if you supervised an APP, it would be another $10,000 above that. The third line I want to walk across then is the 5,500 RVU line. So again, you would take that 5,500 RVUs, the conversion factor at this level is $46 an RVU. So it equals 253. 190 was paid, in this analogy or on this screen, was paid as a base. So there would be a $63,000 productivity bonus. Then the quality incentive at $4 per RVU, a still populated average managed care bonus, comes to a compensation opportunity of almost $280,000 a year. And again, the APP supervision. The way that your base salary language will be worded will be your base salary is going to be the greater of $190,000 or 85% of what you've historically earned on productivity-based comp. So I'll apply that one here. If you're that physician who has shown a pattern of producing at 5,500 RVUs, the productivity-based comp is $253,000. So you say, well, that's not, I don't want to wait for the rest of my payment. I've proven I can produce at the 5,500 RVU level. With that language of 85% of that would go into your base salary, 85% of $253,000 is $215,000. So for that physician, the base salary, instead of being $190, would be $25,000 higher at $215,000. The 253 total productivity offer wouldn't change, or opportunity wouldn't change. It's just $25,000 would come out of the bonuses you would get through the year and would be paid through your base salary on every paycheck that you get. So every year, Lynn mostly and her team would look at your productivity and say, if the calculation of your productivity bonus at 85% of that is greater than 190, your base salary is going to automatically go up to that higher number. You're going to get smaller bonuses through the year of it, but you're going to get more of the money in your pocket sooner. The other thing I want to mention is right now your bonus opportunities are annually. Annually and largely dependent on PHO bonuses. The productivity bonus will be calculated and paid every quarter as a draw toward an annual calculation. So you can't hit it out of the park one quarter and then go to Hawaii for 3 months the next quarter. It's all builds together as an annual compensation. But if your productivity starts going up or starts changing, you're going to get the reward of that within the next 90 days. So the quarter will end, there'll be a 15 to 30 day calculation period compared to what you've gotten as draw and or previous productivity bonuses. And so for the first quarter that ends March 31st, you would have a productivity bonus by April 30th. When June 30th ends, you would have a productivity bonus by July 31st. So you're never more than 90 days away from being rewarded for the productivity that you're actually demonstrating. The productivity bonus would be quarterly. All of the other calculations by necessity would need to be annually. The quality elements is largely due to sample sizes. we can't cram all the quality measures into each quarter, and we can't have a sample size large enough in each quarter without incurring crazy amounts of cost. Obviously, the managed care bonus is going to be driven by the timing of the PHO. And then the profit, the revenue minus expense bonus, is unchanged, and it's at the end of the year, and it's when the managed care bonus comes in, and it's calculated.
The revenue minus expense, you said, doesn't change. For some of us, that may be a bad idea, just given the fact that our expense is a little bit more than some others as far as, does that include, like, how did you come up with that? Is it the cost of the building, how much the rent? How does that work?
On the revenue expense piece, I didn't come up with it. It's part of your current comp, and we basically really don't want to take away from an opportunity that's succeeding for some portion of you. So you're right. Some people have different cost structures, different rent levels, different staffing levels. To the extent that you can have your revenue high enough and control that cost and get to a profit, that's unchanged to what your current opportunity is.
I'm not sure if we caught your question, Doctor. So yeah, the revenue minus expense portion, the 8515 portion, would just be based on your monthly operating reports as they are today. So those again, the kind of the quasi private practice model, we're trying to attribute expenses as they would be realized in a private practice setting.
So I guess my question is, if, for example, Dr. Spielhopfer shares a building with the expense is shared amongst 3 doctors versus me being by myself in one building. Does that affect? Isn't she an advantage than I am?
But potentially, depending on how that ultimately works out, the full cost of that. Yes. So, but again, historically, the only way to do it, and a lot of that, again, going back to the history of the quasi-private practice model, there was some decision-making on the part of the physician in terms of where they wanted to go, improvements that were made to the building, those types of things. If we were to come across with an average cost structure for all physicians, we would actually be taking money from some of them and giving it to others. So again, we try to attribute the actual costs by practice. Now, having said that, some of you, we ask to go in certain situations, and if there's a wide variation in that cost, we can certainly look at that. But it is the actual expense of each provider in their setting.
But it's not a big part of this compensation, though.
Well, it's still, it absolutely is, yeah. If at the end of the year you're in the black, that's going to be, you're going to get 85% of that as part of this. And it very similar. We have a tiered structure now. You get 100% of the first $15,000. You get 75% of from 15 to 50, and you get 85% above 50. So if you're making above 50 grand on an annual basis, you're roughly getting 83 cents on the dollar, which somewhat, kind of closely mimics this in terms of the blackness, so to speak, of your monthly operating report at year end. But also, as Kevin said earlier, all of the costs would be attributed to that. So some of these other quality components or things that we're fronting, so to speak, would then be part of your monthly operating report to find whether or not there was an incentive or a net income at year end. There's a lot to this. That's why, part of our main concern was we're kind of going from elementary school to PhD level in terms of the comp model. So we're going to do more than just tonight. Tonight is kind of introducing the concept, getting your initial reaction, getting your initial thoughts, and we can circle back one-on-one. We could show you, again, our goal is to have side-by-side reporting, spend as much time talking with you as possible, but very excited about what this will offer, both for those that are high producers as well as those that historically have not felt like there is really any incentive for them to work hard.
Speaking of that, I like RVUs. I like I think that's a legitimate way to do it. It doesn't matter here, it doesn't matter. It's Medicare, Medicaid, and RVUs. So it makes a lot of sense for us, because it doesn't matter if all mine is Blue Care and you have all Medicaid, and you're trying to do a compensation pattern. I get higher compensation per patient. You don't. This takes it away. However, what I don't like, if I'm reading this right, is if I work and do 2,500 RVUs, according to this, I get paid $205,000. If I double it and see 5,000 RVUs, I make a whole $44,000 more. Personally, I'm gonna be on a beach for $40,000. So I don't agree with the compensation pattern that you have there. The ones that you can have a set point of what you want as a minimum. If it's 60%, 60%. But this does not incentivize a high producer. It wouldn't incentivize me at all, because if I double one person, if I double myself and do, let's say I do your 30 or 3,000, I get paid 207. If I'm a good producer, I get paid 3 or 305.
So what you're not factoring in there, though, is the shared profit.
No,
if you're a high producer, additive to the row that you see there is going to be an incentive, a shared profit incentive, in addition to the numbers you see there.
All right.
Let me take a stab at it. I understand what you're saying. The productivity part of this really works between 35th percentile production and about 75th percentile production. It works between, I left my pointer, it works between 4,400 RVUs down to 7,000 RVUs. And so you think about the broad stream of 100% range, it works, it doesn't work. There's no productivity incentive for the bottom quartile. Those folks, if we used a fair conversion factor of $50 an RVU times 2,500 RVUs, they'd earn $125,000 and leave. We just wouldn't be able to keep them with that low of production. But between this 4,400 and this 7,000, if you look over here and you say, okay, all in, the incentives that we're giving them, it ranges between $49 and $50.67. So that's a pretty tight range, 1 to 2 or 2.5% per RVU over the range from 35th percentile production to 75th percentile. And that's where the large majority of you should fall. And you're treated fairly within that range. Now you have the people above that top bar in that in that first tier. There's no productivity bonus because I can't make the base salary low enough to where it's fair enough. And the intention is for people not to be in that tier very long. The intention is to get to where you have control, you feel empowered to work harder and be rewarded for it. Now the reason it caps out and it starts going down below $50 down here is because we've now reached the 90th percentile. And there's still an opportunity to earn above the 90th percentile, but it's the revenue minus expense model. So when your comp gets to 370, we can't support it financially unless there's a profit in your department. But I'll agree with you that the way that it's fair is really between basically 35th percentile down to over 75th percentile, and then it caps out.
I mean, one thing to do too is to change that base salary at the, I just, yeah.
It will be.
I get it will because you're gonna do 85%.
Right.
I get that, but it still seems a little bit skewed from at least some of the numbers I've seen on MGMA and things like that. I guess I don't know what your end pattern is gonna be, but people that are you want to drive productivity, you want to drive us to do more, and to do that, I don't want to be, promising things or saying things and then, okay, yeah, this should have happened, but now your incentive that was going to come is not really there, even though you worked this hard, because by combining the two, you're almost skewing us from having a productivity, a whole productivity, I don't know if I'm explaining it right, incentive, because if I know I'm gonna work harder, I'm gonna get paid more, I'll work harder. If I know if I wanna work harder, think I might get paid more, maybe, and I don't really see a lot of me.
If you don't feel like you can get to 4,400 or the 35th percentile nationally,
No,
then the real variable is just the $4 an RVU over in this category. And you're right, there's not much difference between 12 and 16 or 12 and $17,000. But once you get above the 4,400 RVUs, the rate per RVU that it goes up is a very linear, within a couple of percent. That does, not to ignore or finish answering that question, I was supposed to be reminded to talk about the tiers and how it affects on here, and I forgot to. But we'll take the jump between the second tier and the third tier. I want to point out that at 5,200 RVUs, the productivity comp, which is the base plus the production incentive, is $28,800. And if you do one more RVU, so you get to that third tier, it's calculated on every RVU, not just the incremental rate for each new RVU. That one RVU between 5,200 and 5,201 is worth a little over $10,000, almost $11,000. So there is a direct incentive toward getting toward each new tier. The reason that's important is because the costs are, it drives fee-for-service revenue, which aligns your incentives, and there's a base amount of cost, that cost structure that you were talking about. Rent doesn't go up if you see the difference of higher RVUs. Rent is a fixed cost. There's a certain amount of fixed costs and variable costs in every practice. We have more opportunity to cover those fixed costs, and therefore, without waiting for the revenue minus expense calculations somewhere down the road, we're willing to recognize that you've covered more costs and give you that incentive between those steps.
I guess that's an opportunity to kind of compensate for what I'm thinking in my mind, but how did you get the rates for those three tiers? Good question.
They're backed into, they're judgment factors, and is what we want to arrive at is ignore the APP supervision for a second. This right here is your general opportunity. It doesn't take into account signing bonuses, student loans, or whether you have a profit in your department. It says the three major things I have are my productivity comp, which is my base plus what my productivity comp is, plus my quality incentive, plus my managed care opportunity. This number here, relative to your work, has to be fair, comparable to the market data.
I think, isn't market value though about 49.57 per RVU?
Is right around $50 per RVU is median nationally.
But see, we're getting that $50, but that's only by adding in the quality incentive, the product.
And that's exactly what's in the market data too. The way the market data is accumulated, remember, let's go back to 80% of the people responding to the market data are on something like this. The way the question works when you respond to the market data, it says, tell me your compensation from all sources. So it's every one of these elements if they have that as part of their compensation plan. Separately, it says, tell me your RVUs or give me your CPT codes and I'll calculate your RVUs. So those RVUs are divided into the comp with those elements in it.
And we need to show each physician based on previous performance, how this model would pay out, because again, the further down you get there, that column G becomes relevant. And there is, in all probability, not in all probability, there is a black net income at year end that you're going to be sharing in. So, and that ultimately is going to change that total compensation. So part of this, we all need to see how this will affect you based on more recent or past performance. Dr. Costello?
I don't see a column for uplifts for Blue Cross Blue Shield. So we all, because of our participation with patient-centered medical home quality and other things, we get either 20 to 40% uplifts, which is above standard or fee-for-service. How is that factored in?
It goes into the revenue that's part of your revenue minus expense model. As Dave mentioned, that, this isn't the last time to digest this, understand this, and we're going to have more meetings either with them or me via phone or whatever else. But this page, we're in the process of preparing one of these for each physician. This one is an example physician. It's because I love numbers and can talk about them forever. It's some of the same modeling that you've seen, just in a different format and applied a different way. But this is very close to the average doc once you take out some outliers within your group currently. And that is a doc producing around 4,100 RVUs and making $205,000, almost $206,000 a year. So that's the current state. If that exact same productivity was in place on this compensation model, it would be below the bonus level for tier 2 and tier 3, so the conversion factor would be $41, the base would be $190. There would therefore be no productivity bonus, but there would be the quality opportunity of $4 per RVU, and again, I populate with your average managed care, 10% of the average managed care. So the total comp earned on this would be $211,000, or $5,400 higher than that. The next two columns, we just did simple math. We just said, so you don't have to go run it through yourself, say, well, if I could see 10% more patients, or if I could see 20% more patients, how would I look on this compensation model? So these right here are just 10% higher and 20% higher. It does kick into tier 2 because it goes above that 4,400 RVU level. It does kick in there, therefore, to a productivity bonus. The quality opportunity is a little bit higher because it's $4 per RVU. And so at a 10% more work from that physician's current workload, it's $16,000 raise. At 20% more productivity, it's $36,000. The last two columns are going to be populated specific to you when you get it, is some work out of the access initiative. Is what would we like, what management's worked with you, looked at your practice, what do we think that this physician can reasonably accomplish given their location, their patient mix, and stuff like that? So Dave and Iris and Lynn and others have sat down, and those are in the process of being populated, and saying, this physician, we think with the appropriate supports, should be able to get to that 60th percentile that we've been discussing. And so it models and says, okay, if that happens and we get the right supports in place, we build the practice up and we accomplish that. I think I actually populated this at 50. No, I did at 52 even, because the math was there. If it was 5201, it would be $9,000 or $11,000 higher. But at slightly above 5,200, you get, in this one column here, it's the 5,600. It does get to that tier 3, the $46 per RVU, and it shows what the compensation and the reward, the compensation level and the increase, I guess, from the current compensation, if that's the direction that the RVUs go, and you get above the 70 or above the 60th percentile of RVUs. So you'll, besides just using that previous page and saying, oh, I think I could be on this line, this is going to specifically look at your current run rate and say, okay, here's what your run rate is if it's 10% more, 20% more, and here it is relative to the access initiatives that's been being discussed. I get one other answer to your question about how was the conversion factor, or the 190 or whatever. I explain it sometimes in the context of it's a balloon. The balloon can be a certain size, and we can move stuff around. We can increase the conversion factor and lower the quality element, or increase or lower the conversion factor and increase the quality element. We run afoul, or we run a risk of a compliance environment if we just add everything. If we raise the conversion factor, raise the quality, and raise the percentage managed care, sure, everybody would make more, but we would run at risk of that compliance of being fair market value and commercially reasonable. The way we get over that is if there's no financial support, meaning your department's in the black, we get to take the cuffs off of that compliance part and say, when we get there, now we can share the profit 85-15 without that same compliance risk.
We had planned to go till 7:30, and we're about 6 minutes away from this. So again, we know this is a lot. Tonight was to kind of introduce the concept, at first blush, talk about it. As Kevin indicated, we're working on individual pages for you. So Lynn and I and Iris are going to be burning a lot of miles, just meeting with you both individually, collectively, again, trying to get the word out to others that missed this evening. For those of you that are in a June 30 termination mode with your contract, our intentionality is assuming we can get, because this all has to be kind of memorialized in a new Exhibit B that will be attached to your contracts. Our thought most likely is that this would be available for those that are intrigued and interested, and we can get you understanding it, you're excited about it, etc. Obviously no sooner than July 1st, but we do have your holdover term that we can go up to 6 months. And again, if this all falls flat and this is something that we don't want to collectively pursue and stay with the current system, we absolutely can do that. But there's some intrigue that we have that can get money in your pockets earlier if you have some intrigue to join us in that, obviously. So we can extend current contracts no later than 6 months, so we've got plenty of time to continue to talk about this and have this available, again, for those of you that are June 30 of this year, no later than January 1st of 2020. So plenty of time. We'll be available. Email us, call us, holler at us. We'll absolutely be available to show you how this will impact you both individually and collectively, and appreciate for those of you that made it up tonight to come this evening. So any final burning question? Yes.
As far as the managed care bonuses, what is our thought, because this is a brand new year for us for what the PHO is planning to do? I mean, do we have any idea of what those bonuses are going to look like yet?
We do.
Okay.
I've been talking with the PHO, Dan Kramer and Gail Biederman, as late as just last week. They anticipate this year to mimic the prior 2 years. So we should be very, very close to what we've historically been running.
Because I think, a concern of mine is we're looking at this and, part of that is the quality and the managed care bonus, and hopefully the quality will improve when the survey gets better, because most of the patients don't want to answer all those questions. And so that your numbers are not as big, and so to me that's a factor to get that quality money, because patients don't want to answer all these questions.
Actually, these quality metrics are pulled off of Epic based upon your individual patient population.
Oh, I thought it said patient satisfaction.
That's one component of it. So you're correct.
Oh, I'm sorry, the quality measures.
Quality.
The quality
Yeah.
comes directly from Epic based upon your panel, as opposed to the PQRS survey.
Oh, it's not part of the survey. Okay.
But the patient satisfaction is the survey.
Oh, so it is part of the quality, yeah.
Yes, you're both saying the same thing. So yes, the patient.
So the survey is in there still?
The survey is still in there, and yes, starting July 1st, we are doing a new survey. So we're going back to just the press
So
survey.
that's a concern, because, not everybody wants to, I saw this. Yeah, so there's a survey, and so the screenings, obviously we try our best, not all patients are gonna do that. I wish they would count those that we ordered or denied or whatever, because that hurts you, right? I mean, and I'm not gonna discharge my patient because they refuse every screening test. And here it's almost like, now I'm not gonna get paid because you're not doing these tests and you adamantly refuse. That's hard as a physician, right? Because we're recommending it, we're talking to them, or what can I do for that patient that just can't afford their insulin anymore, and so their A1C is gonna go through the roof, and now we're getting,
They can't afford other.
Yeah, I mean, it's hard, and here we're getting, that's based on our pay, it's not totally fair, I mean, we're trying our best to do that, but that's a little concerning for me, because here we're talking about the fair market value, we're trying our hardest, we're seeing monthly patients, and this quality may drop, and our pay is gonna drop based on things that may not be in our control, so yes, we wanna order our screenings, we wanna do all these good things, and all of us are here to help our patients, nobody wants us to have an uncontrolled diabetic, but it's,
Right, but it was also first blush what the quality indicators are going to be, and I think that we're going to need your input as to what are the most important things that we should build into this program. So say, for example, for this year, if it's A1C, then it's not going to be 100% of your patients need to have an A1C less than 8. It's going to be maybe, 60th percentile of the patients, something like that.
Okay.
So I think that there's a conversation that will be had before we finalize what's in or what's out.
Be respectful of time. So again, thank you for this evening. A lot more discussion, both collectively and individually. So thanks again.